June 1981. So it's been with us for almost like 42 years. And it was first diagnosed in San Francisco among 4 or 5 homosexual men. And ever since then, the disease has been a constant presence in our world. Unlike COVID pandemic, which hit us hard and hit us fast, HIV has been a steady presence in the last 40 years, So as of 2022 December statistics, we have about 38 million people globally living with the disease, and of which 28 million people have been on treatment. So that's not a bad figure at all. And compared to right from the day one to now, and statistics of like end of December 2022, about 84 million people have had HIV, a diagnosis of HIV or AIDS in these 42 years, of which we have lost 40 million people. So one in two mortality. But remember, this mortality or deaths which used to happen were in the early years when we did not know much about HIV, we did not have much medications, and all those kind of things. So the mortality was higher those days. So what will definitely enlighten, hearten us is the fact that there has been a decline of 32% in the incidence of new cases, and there has been a decline of 52% in mortality compared to what it was long back. And even amongst the 38 million people globally, 25 million people are in sub-Saharan Africa. So that's a significant number that we are living and dealing with in Africa. The good news is the 38 million people, 28 million of them have some kind of access to medical treatment and drugs, so which is again a very good thing. And even amongst the 38 million people, 85% of them actually know that they are positive for HIV, and 75% of them are on medications, and 68% of them have really gone to what we call as undetectable levels of virus in their bloodstream. So that is a good piece of news. So most likely it is because people have become more aware of this disease or condition, and they are also adopting preventive and treatment measures, and there's open acceptance to the fact that this condition is not a curable condition, but it's something you can live with.
And of course, we'll definitely want to know some more about treatment. But even before it gets to that point, just what is the distinct difference between HIV and AIDS?
Yeah, many times I get to see this. People try to use this HIV and AIDS interchangeably, which is not the case. HIV actually stands for human immunodeficiency virus, right? It is the virus that can cause the disease HIV, so it is the name given to the virus or the infection, whereas AIDS stands for acquired immunodeficiency syndrome, which is now one of the stages of HIV infection. So having HIV doesn't mean that somebody has got AIDS. One could have HIV infection and they can continue to stay with the infection in what we call as a latent infection, and without having the obvious full-blown features of the disease. So in order to understand this, HIV is a virus that targets a particular type of cell in the blood. These are called as CD4 lymphocytes. So what the HIV virus does is it gains entry into the body and starts attacking the CD4 cells. So without treatment, the CD4 numbers go down tremendously, and then it exposes the patient to having infections and certain type of cancers. So the advanced stage of HIV, obviously, without treatment is what we call as acquired immune deficiency syndrome, which is what the patients eventually will get, let's say in about 10 years or so from the first diagnosis. It can happen much earlier depending on certain social and economic parameters, and even the personal health of the patient. It can be much rapid than the 10 years time frame I told you about. And that in a sense is the main difference. HIV is just the virus which causes HIV infection, and AIDS being the last stages of having HIV infection.
All right, so can there be a reverse on HIV then, and especially when we're talking about treatments, and one out here sometimes people will tell you, well, there's medication that can totally reverse this upon diagnosis.
Yes, there is, I would not say reverse. Like I mentioned before, HIV has become what we call as a chronic manageable condition. Much like your hypertension or diabetes, it is not curable. But you can definitely keep the virus to such low levels of suppression that the patient is no longer going to get into the stage of AIDS, what we discussed, or the patient will no longer be as infective as anybody who's not on treatment. Yeah. So, and of course, while we were discussing about HIV and AIDS, we probably should know about the stages of this infection. So, let's assume that somebody has come in contact with the source of HIV, and not everybody, but some people can now have what is called as an acute HIV infection. Now, 2 to 4 weeks after being exposed to the source, they develop a very flu-like illness. They get like fever, headaches, rashes, diarrhea, and swollen lymph glands. And this phase is called as acute HIV infection. It used to be termed as progressive glandular lymphadenopathy and all those medical terms, but we'll stick to saying acute HIV infection. But keep in mind, in this stage, the patient is actually showing signs of high transmission. The virus is multiplying rapidly, and the patient is super infective at this stage, and he can actually spread it to others without knowing that he's acquired the condition. So that becomes a very critical thing when we discuss about investigations. We can just have a chat about that. And once a patient has been diagnosed with an acute HIV infection, and there are two ways. Some people opt to go in for treatment, some do not go for treatment, but we recommend the treatment has to be started as soon as somebody has picked up this early HIV infection. So with treatment, a majority of them can end up in a state what we call as asymptomatic HIV infection or latent HIV infection, whereby the virus is multiplying at very low levels in the body, and the drugs that we use will keep this virus suppressed and prevent patients to get into that advanced stage, what we discussed as AIDS and acquired immune deficiency syndrome. And of course, in people who do not have the ability to get these medications, maybe because of cost effects or whatever, they obviously will get into this stage of AIDS, whereby the body has lost almost all its CD4 counts, and the patient is now unable to mount an immune response, and they pick up funny and strange infections, which we call as opportunistic infections or cancers. So once a diagnosis of AIDS has been made, the lifespan from there is roughly about 3 to 5 years.
All right, so those are the basics that are very, very important. To what point then can we say there's some essence of prevention, and one would want for us to be walked through these processes so that you can say, well, fine, there's a way you can prevent HIV infection as soon as, of course, you are aware of this.
Yeah. Well, in order to know how you can prevent something, you also should know how you can acquire something. Okay. Right? So we need to discuss about how it can be acquired and how we can prevent it. So just before that, I quickly want to also talk to you a little bit about testing. You know, many times it becomes like, it's almost like HIV has got a taboo or a social stigma attached to it. So people have this fear or misconception that, oh my God, if I go get tested for HIV, and if it turns out positive, I'll be ostracized by the community and this and that. So I would like to advise at this point in time that getting a diagnosis of HIV is not a death sentence, like you mentioned very clearly in the beginning. But it is very important to get tested, primarily for the fact that if you know your status, you will be more responsible and you will prevent the transmission of this disease in the society. So that's why it is important. We have a body called the CDC Atlanta in USA, Center for Disease Prevention and Control and Prevention. The CDC recommends that every person from the age of 13 to 64 get tested at least once in their lifetime for HIV, and more often if they have certain risky behavior, which we'll talk about in a little bit. Primarily, there are three main types of tests healthcare providers will do. One is called as an antigen test, one is called as an antibody test, and the other one is what we call as a NAT or a nucleic acid test. Without getting into too much technicalities, it's important to know that majority of us, when we go for an HIV test, will be provided either an antibody or an antigen test. The NATs are expensive, and we don't generally do it for diagnosing day-to-day acquisition of the HIV infections. So whenever a patient has been diagnosed with one test, it is always imperative that we send them for a confirmatory test. You don't really brand somebody as being positive for HIV without doing a confirmatory second test. And assuming that the patient tests positive on the second test, then it now is obviously true that the patient has got HIV.
So there are instances where one can, with the first time test, and it's
exactly. You can have false positives or you can have false negatives. So we need to confirm it by doing a confirmatory test. So we obviously always do 2 tests. And the other thing very important for people to understand is there is something when it comes to HIV, it's called as the window period. Okay. Now, supposing a person has been exposed to HIV, let's say through casual sex or whatever, and he's exposed to HIV, he decides, okay, I need to go and get myself checked. So he may actually go to the laboratory and get a test done and comes out negative, and he's very happy that he has not got HIV, but he needs to be very careful because of this window period.
So how long?
The window period is roughly about 3 to 6 months. So you cannot immediately pick up the HIV on a normal test when, supposing somebody had an encounter last night and this morning he gets very scared and goes to the hospital and he tests it's negative and he's happy, and he might actually go around spreading the disease, considering that he is negative, but it is not. So you need to be very, very careful in those 3 to 6 months. You need to continue to do all the preventive measures that you will take anyway, so that you don't inadvertently spread this to somebody else because you're negative, and you may actually not be negative, you might be positive. So that's called the window period. So people have to be very careful about this window period.
Yeah.
And apart from these tests, what we discussed, once a patient is diagnosed with HIV, we do certain additional tests. The most important, of course, is the viral load. And the other one is, of course, the CD4 lymphocyte count. When I say viral load, it means it's a test where we talk in terms of the number of the HIV virus particles which is present in the bloodstream. And when I say CD4 count, we know that HIV virus attacks the CD4 cells. So as the CD4 lymphocyte count keeps going down, the patient is obviously exposed to opportunistic infections and cancers, like which we discussed previously, in the stage of AIDS. So the good thing about viral load testing is, in a patient who is HIV positive, and if he or she is strictly adherent to the medications prescribed by the doctors, it's extremely possible that they can get down to a level of almost undetectable virus in the bloodstream. And you'll be surprised, when they have undetectable viral loads, they can actually lead an entirely normal life, and they could continue to have, a normal sexual life with their partners, although there is a very negligible risk, but the risk is much less than when somebody has got detectable viral loads.
Well, thank you so much, Chitari, for getting us through that moment of testing and all that. Lots of myths out here that it's easy for a woman to get HIV and AIDS more than a man. Is it true?
Actually, in a way, you're right. If you look at the statistics again, as I said, there are 38 million people living with HIV, and some 54% of that is women and adolescent girls. Traditionally, if you look in a heterosexual society, women are the receptive partners. So always the risk is more for a receptive partner than for the other partner. And it also happens in a society where there's homosexuality. The receptive partner, of course, is at more risk than the giving partner. And also the other thing is, women and adolescent girls generally are hesitant to go and get or seek early medical help or medical interventions, and they're probably, bound by society not to go for testing and all those kind of things. And again, in some societies there is always there's more of women who work as CSWs or casual sex workers. So you probably would notice that more women are in this profession than men, of course. So it's always a slightly skewed social factor there. But you are right, about 54% of the people living with HIV are women and children. When I say women and children, it's important to note that a pregnant woman can transmit the disease to the unborn baby. So which means that if a woman is pregnant, if a woman is HIV positive and she is pregnant, now you already have another patient brewing. So we will discuss about what is called as perinatal transmission or mother to child transmission. So that is now one of the things why we need to take more good care of women with HIV who get pregnant.
So in this case, then we get to the aspect of prevention, understanding in depth.
Yeah. When we go into prevention, and yes, we will probably have a little chat about how this can be circumvented.
All right, so how about we take a short break and then we come back to the aspect.
Thank you.
Ladies and gentlemen, karibuni sana. This is Dr. Frankie tonight. And of course, on to our first guest of the night. An amazing actress, an award-winning actress, one of the top influencers right now, a top brand ambassador, ladies and gentlemen, and a lady who I respected, of course. I'm proud to call her my friend. Ladies and gentlemen, DJ listening, are you ready for something there?
Yes.
You ready, yeah?
Yes.
Give me something, yeah? Ladies and gentlemen, the one and only Kate Kamau, a.k.a. Kate, actress. What's this? How much material
It's
is
a
this?
lot. It's a lot. I mean, I'm a lot.
Does it even like, is it like normal time to wear like 10 minutes?
Asha.
Ama like lazima uipangie.
Hii lazima shida ni kwenda kwa choo hiyo tu. Yeah.
But they come to think of it, madam of a jumpsuit. How do you guys go to the washroom? How do you guys deal with that
That's
whole
why
thing?
we go in pairs to the bathroom.
No, men, you never find men going to the washroom in pairs. Where Richie? Richie niaje. Nasikia kusojo. Hebu tuishie. I think ladies are so privileged. You guys can even call each other boom, babe, sweetheart. Imagine now me I'm now calling Richie. Richie babe, niaje. Unakamjobosa ngapi na saxophone?
But we are okay with that.
Never.
Yeah.
Kate, welcome on the show. You are our first guest ever. Piga makofi. Ndio nimetu mpya tuko na interior design round hii.
Hii ni Wajakoya ama
Check relax. Usiseme na nguvu we. Nakada wana watch, nakada.
ni sponsored.
Let me ask, have you ever tried?
No, what is that? No.
Haujawahi? Under by mistake.
But now I know it because of Wajakoya.
Oh really? So hujaipita kwa campaign ya Wajakoya by mistake ukaisikia? Have you ever tried drugs at any point?
Which one?
You're a clean,
I'm a
good
role
girl.
model.
Role model. Sawa kwa Listen, do we have enough role models in the industry anymore? Or because I've seen these days people do their own things, they mess up on social media, then they come and say, listen, I was not born to be a role model, I'm living my own life. Do you think that is the correct way to handle it?
And I think what Akothe says, I did not choose to be a role model. It's my career that inspired you to give me that title. So you cannot give me the pressure to become a role model. That's how you feel. So that's how you interpret my brand. But I have to live my life. I'm not telling you to live the way I live. You understand? But I know I have a responsibility as a public figure to act in a certain way. But in the same breath, I have to live my life truthfully, being me. If it inspires you, yes.
Well and fine.
If it doesn't, good. Yes.
Let me ask, which is like the most weirdest story you've ever heard about you? Ile mpaka uko like guy. Todie.
Like I'm very mean, I'm a snob. I think I'm too friendly actually. I'm too friendly.
All right, welcome back to the broadcast and in our mini studio right here at the Diani Beach Hospital at the South Coast. We are talking about the business of HIV and AIDS, and Dr. Rad Gopal, who's a consultant physician at the Diani Beach Hospital, is the one who's taking us through. It's very important that you check them out. Lots of facility, or lots of anything that you want to do or to get in terms of matters held in this very facility. And everyone, doctor was taking us through as we're trying to understand. So if you missed out on that part, you need not to worry, because we have this streaming live on our social media platforms. So once we're done, once you get the basics of this, you can always go back and find out how best you can reach out to the Diani Beach Hospital. But yes, to the subject matter, that is HIV and AIDS. We've talked about the basics, and now we come to the aspect of treatment, which is crucial.
As I said, that with treatment, the viral loads can be very low. So it's imperative that everybody who's got a diagnosis of HIV should start treatment at the earliest possible opportunity. Some few years ago, we used to wait for the patient's viral load to go beyond a certain level, or the CD4 counts to come back to certain levels. But right now, the new school of thought is as soon as somebody has got a diagnosis of HIV, he or she should be started on medications. And it's imperative that in the acute HIV infection, which I was talking about earlier, pregnant women and those who have AIDS-defining conditions, which is opportunistic infections and cancers, certain cancers in this condition, we should put them on medical treatment as soon as possible. It's interesting to know that initially, in the first few years, people used to be put on like a cocktail of drugs. Some of them were taking like close to 8, 10, 12, 15 pills a day. And inevitably, they used to have a lot of side effects and interactions. And people would just say, oh, I'm feeling sick with the medicine, I'm not going to take it. And that would lead to non-compliance. Remember, I always tell that a patient with HIV should be compliant on the medicines. Only then the virus is going to go down to below negligible or suppressed levels. Thankfully, the current management of HIV, we use a combination of 2 or 3 drugs, not 2. We use a combination of 3 drugs, and most of the times you see that the patient is just probably taking 1 pill a day or 2 tablets a day, which means compliance is no longer an issue. And also they have very few side effects compared to what it used to be before. So that means more and more patients are now able to take the medicines without side effects. And of course, very important is it also adds a lot of importance to the cost factor. You know, imagine if you're taking 10 or 15 pills and each one costs like, let's say, 1,000 shillings, your monthly expense is immense.
Right.
In developing countries, we cannot afford that. So with the current management, what we have, 1 pill a day or 2 pill a day, the cost also has come down significantly. So, of course, I will not get into the details of what medications are used to treat HIV, because that is not the forte of this talk.
Right.
We would rather leave it to the healthcare professionals to discuss with the patients and then put them on the necessary medications. But it's important to understand one thing, that when somebody has got a diagnosis of HIV and if they've been started on medications, please make sure you take those medicines every day without skipping a single day. You know, the virus is very smart, because if you skip medicines for a day, you let the virus now escape the control mechanisms, it starts multiplying, and then you're going back 2 steps. You know, you need to always be 1 step ahead of this virus.
Right.
So I always insist and tell my patients, some of them buy on a monthly basis. So you just tell them 2 or 3 days before you finish your medication, please come back and get a prescription refill. And you know, it also gives us an opportunity to keep a check on you and see how you're doing and those kind of things. The other interesting thing is, as I told you, almost like 70% of the infected people are living in sub-Saharan Africa. Now, you would not put sub-Saharan Africa in the top 5 or 10% of the wealthy countries in this world. So for us, it becomes challenging how best we can deliver medicines to people who need them actually.
Yeah.
So thankfully, a lot of international interest has been raised on this, on HIV and its management. We have a lot of charitable organizations, we have a lot of global stakeholders who have entered in a big time. And then you may also know that some of the government hospitals in Kenya, they provide medicines free of cost to patients. So all this is possible now because of all these global ventures. So I think we have reached a stage where we are able to now have a better control on HIV, and that is in itself, the declining incidence and mortality should tell you that something is being done appropriately and correctly. So I feel that is a silver lining in this entire HIV and its related conditions.
How silver has it been for the toddlers, for the infants, for the young ones? I have personally seen a baby trying to struggle to swallow the pill, and it's quite uncomfortable. Have we officially gone into that level where they have syrups?
We do have syrups, yes. We do have syrups for children, especially in neonates, so like 1 day old, 2 day old or whatever. You can't expect them to have tablets, and some of these tablets obviously cannot be crushed and given. So we do have syrup formulations of majority of the commonly used antiretroviral drugs. Oh yeah, by the way, like medications, you must have heard of this thing called ART or HAART. So that means medicines used to treat HIV are called as the phrase is antiretroviral therapy, that's ART, or sometimes we use HAART, is highly active antiretroviral therapy. So we do have them in various formulations, and of course we cannot leave the infants behind, and obviously we are blessed to have many pharmaceutical companies trying to make liquid formulations of these medications.
All right, so lifestyle during treatments, I am told it's very, very important as well, because it's someone who will take their antiretroviral drugs, but at the same time will be out drinking, will be out, with a terrible lifestyle. What would you say, basically about that?
Yeah, if you see, majority of the times I say we human beings, right? I'm not going to point at anyone in particular. We human beings, we always believe in the concept that if I have high blood pressure, if I have diabetes, if I have HIV, I take a medicine and I can continue to do what I want. It is not right, because even if you look at a disease like diabetes, for example, you put these patients on medications, but you still expect them to have certain lifestyle changes like weight loss and avoiding smoking, alcohol, and these kind of things. So even for a patient who has got HIV, it is not that he just pops 1 or 2 pills a day and then goes around doing the high-risk behavior that he or she used to do.
Yeah.
You need to rein in yourself. You need to obviously have access to nutritious food, you need to have access to good healthcare facilities, and you need to have access to regular availability of medications. And also, as I said earlier, if a partner is HIV positive, irrespective of how low their viral load is, it is important that they still continue to follow those, safe sex and all those kind of things, which we will discuss in a little while.
Yeah.
So yes, lifestyle is very important. And it is not that I just take the tablet and I continue to lead my gun life, and I think it would be a bit foolhardy to do that.
All right, briefly on pre-existing conditions. I mean, you have been diagnosed with HIV, and at the same time you have pre-existing conditions, so perhaps you're in medication. How do you balance this? Is there a problem?
Yeah, what happens is majority of the patients who have acquired HIV, thankfully, were in a younger age group. Normally, the casual sex workers, everybody like 20s, 25s and whatever. So maybe they did not have any comorbidities like diabetes or hypertension. But yes, when a patient has got other comorbidities like diabetes or hypertension or probably even hepatitis B and C, which are also acquired incidentally through similar mechanisms like HIV, they will be now on other drugs, and so the doctor or the healthcare provider will now have to take into consideration the drug-drug interactions and all those kind of things. So we would obviously assess the patient as a whole, and we would look at them in an entirety and see how best we can tailor make medications for the disease, the HIV as it is, and the coexisting conditions.
As they will always say, prevention is better than cure. So at this point, some more about prevention.
Yes. So as you rightly said, a stitch in time saves nine, or prevention is better than cure. In order to know for us what we can do to prevent the condition, it's also imperative to know a little bit about the transmission of HIV, right? So there are a lot of misconceptions. I have even heard, I've even seen people saying, no, he's got HIV, don't shake hands with him, don't, it's just like sometimes you find that. Yeah, exactly. So we probably need to talk a little bit about how HIV is spread. Mainly, HIV spreads by person-to-person interactions, and it's called as transmission, right? So a person who has got HIV, we all have body fluids, okay? So the body fluids are the main vector for transmission of HIV, and when I say body fluids, it includes blood and blood products, semen, the pre-seminal secretions, the rectal fluids, vaginal fluids, or even breast milk. So all these 6 are the known or documented means by which HIV can spread. And for a person to get infected, the mucous membranes have to come in contact with any of these fluids I mentioned before. So we all have mucous membranes. We have mucous membranes in our mouth. We have it at the tip of the penis, in the vagina, in the rectum. So whenever an infected person's body fluids come in contact with any of these areas, the risk for getting HIV is obviously manifold. HIV cannot spread by tears. It cannot spread by saliva. And it will not spread by the mucus when I cough or sneeze, right? And it also will not spread by touching a person, by shaking hands, by hugging them, or by even probably closed mouth kissing, right? And again, of course, sharing of utensils, maybe toilet seats, doorknobs, they are all not vectors for HIV transmission. Primarily because the HIV virus is obviously not capable of surviving outside the human body for more than 5 or 10 minutes or whatever is the time frame. So the other thing very commonly is that there is a particular subsect of high-risk population who are what we call as injectable drug users, recreational drug users. So if supposing somebody is sharing needles and you inject into the bloodstream and you take the same syringe and the needle and the next person injects, so that is a definite no-no, because that is one of the main reasons why HIV is very common amongst injectable recreational drug users. So how it spreads, obviously when someone comes in contact with body fluids. Now, mechanism of entry is obviously through unprotected vaginal or anal sex. When I say unprotected, it means not obviously using condoms or not using them properly. So that is one of the main means of transmission of the disease. Through transfusion of blood and blood products and organ transplantation, it is a theoretical possibility, but thankfully, due to stringent screening protocols, we don't have to deal with that in many cases right now. So it's probably very little, unless the blood has been not screened and has been taken from a scrupulous source or whatever, then it's a possibility. The third possibility we discussed was obviously needle sharing. Fourth possibility is occupational exposure. Healthcare workers, we are exposed day in and day night to blood and body fluids. Supposing you have a surgeon who's operating in the theater and he pricks himself while operating, so it's a risk for him. A nurse who's giving an injection to a patient who's HIV and she pricks herself accidentally. So healthcare workers are also a slightly increased risk than compared to the common population. And lastly, as we discussed, the mother to child. A pregnant mother can transmit the disease to the unborn baby at all stages of pregnancy, childbirth, and during breastfeeding. So those are all now the ways how HIV can spread from person to person. Important to know, HIV does not spread by mosquito bites and tick bites and insect bites and all these kind of things. We get to hear all these kind of funny stories, and some of the people who are not so literate enough will avoid to sleep in the same room because of mosquitoes and whatever. So, yeah. So those are all like definitely not documented methods of transmission. We spoke about now how we can acquire it. Now, obviously, the next step is how we can prevent it.
So, but the virus, once it's out of the body, just how long does it stay active and alive?
You get to hear random figures. Some people say that the virus can be gone in about 60 seconds. The virus can be destroyed in 3 to 5 seconds because UV rays, the HIV virus cannot survive in UV rays. So, yeah, once you take the blood and body fluids outside and leave it for a few, let's say, seconds to minutes, it should be inactive. But that doesn't mean that you can go and take that, and it's a risk anyway. It's just definitely not worth playing around with blood and body fluids in any way. So, yeah. Majority of the way is basically, as I said, person-to-person interactions.
Okay, so the prevention.
Yeah. Now coming to the most obvious thing, like the whole gist of this conversation was prevention, and prevention is better than cure. So every one of us are at risk for HIV. So our first prevention is to understand that we are all at risk for HIV, and majority of the times the risk is now guided by our own behaviors.
Yeah.
So, people who have high risk behaviors like too frequent casual sex encounters, because you do not know about the other person. Okay, so when you go in for a casual sex encounter with a person whose status you're not aware of, you're putting yourself in big risk. So my first and foremost advice to people will be to avoid having casual sex encounters. If it is inevitable, it may be better for the person to talk to the person with whom is planning he or she is planning a casual sex encounter, that they go collectively and get mutually tested. Again, remember that mutual testing does not mean anything, because I or somebody else could be in the window period. So it means that you need to make sure that if you are planning, or somebody is planning to have an encounter, they should take all the proper precautions, which includes wearing condoms and wearing it rightly. All these are important things. And the other thing, of course, I would advise the subsect of people who use needles, like intravenous recreational drug users, definitely not to share needles, and try and use, if they have to use a drug, try and use disposable needles and syringes, because that is one other preventive thing we should look at. And I would also advise people not to put themselves at risk for any other sexually transmitted diseases, because it has always been seen that one STD follows the other STD. So you obviously would need to cut down on having multiple sex partners and those kind of things. So sometimes, if you go back to prehistorical times, one of the best methods of prevention is obviously abstinence, but none of us is a saint. So you probably would not go to extremes of saying abstinence is the best form of prevention, but in its stead, what I would definitely recommend to all people is that take precautions every time you're having a sexual encounter with somebody whom you do not know.
But with your partner, also, of course, sometimes there's a danger to this. And there are instances where I have heard, I don't know how true this is, that these people are partners, one of them is HIV positive, the other is not, interestingly, and especially the man, if the man is not, they really do not get infected, even when they did not use much of protection. How possible is that?
I mean, it's like a Russian roulette. Okay, so I can give you a gun with 6 bullets, remove 5 and rotate 1, and then it's a chance factor. I would never take such a chance. First and foremost, if there is a couple or two people in a relationship, you need to be open. You need to tell your partner that you have been diagnosed with HIV, and it's imperative that the partner now obviously gets tested as often as possible, so that you can actually pick up if the virus gets transmitted. And more importantly, the partner who is positive should be advised and advocated to start the antiretroviral medicines, because it has been documented that you can bring down the virus to so negligible levels that your risk, the other partner's risk of getting HIV can be really minimal. So it's important that partners talk and discuss, get tested very often, and do all their medication adherence, get tested for viral load and all those kind of things. So as I said, if you're living with a partner and if you know each other's activities and everything else, it probably is safe. But as I said, we have to stand for ourselves, and you just need to make sure that you take every single precaution. If you think the way I am discussing and talking with you, you may be thinking that I'm saying this is a death sentence, but like we discussed in the opening gambit, it is not a death sentence.
Yeah.
It is obviously a chronic manageable condition, but why get into a state where you have to now take medicines and do this and that? So yeah, it is good. We always need to be careful, and we need to make sure that we take all precautions like what we discussed. The other thing is obviously preventing mother to child transmission.
Right.
Now, as we discussed, there's a vast majority of women and young girls, adolescent girls who are living with HIV, and inevitable that they will get pregnant at some point of time in their reproductive career. And when they get pregnant, there is immediately 100% risk now to the unborn baby. And it can be at risk during pregnancy, during childbirth, and during breastfeeding. So our advice is all pregnant women must and should continue taking the antiretroviral medicines throughout their pregnancy, childbirth, breastfeeding, and of course onwards too. So we have seen that when they are adherent to medication, they're compliant with medications, they have suppressed the viral loads to almost negligible amounts. But still the infant is at risk. You can imagine the baby is floating around inside in the mother's body fluids. So it is at risk constantly. So as soon as a baby to an HIV pregnant mother is born, we should encourage starting HIV medicines within 6 hours of delivery.
Okay.
And the child, the neonate or the infant is now given these medications for almost 6 weeks. Okay. And the child is of course tested at birth. You test at 2 weeks, you test at 2 months, and you test at 4 to 6 months. You do 4 tests. Some facilities do 3 tests. And at the end of that 6 months, if the child is negative, very, very good, no problem. There's no further need to take on medications. But if the child indeed turns out positive, then now the child has to be on highly active antiretroviral therapy. And a word of caution to all mothers who have delivered, that if they are HIV positive, they should abstain from breastfeeding. As harsh as it may seem that you don't want to feed your own baby, but it is important in the interest of the baby that you don't want to give. We said that HIV spreads through breast milk, right? So it's important that we don't put the baby at risk, and we should ideally advocate use of properly prepared formula milk for these kids, for these babies, so that they don't get the risk of acquiring HIV through breast milk. There's a theoretical possibility that if a mother is got undetectable levels of virus, she may breastfeed, but the risk is still there. The risk may be still 1%, but you don't want, again, it's all about risk management. We don't want to get into that 1% risk and put that child's life at risk.
So the formulas would work.
The formulas is the best, and I'm sure, it is something that they have to accept, and in the interest of their child.
Okay. And they used to talk about abstinence, which we all agreed we don't want to look at that as the main form, which is anyway, but here is a reality. And so we get to a space where people talk about PrEP and PEP casually without proper understanding of that. Could you please take us through that as a form of prevention?
Yes.
I want to believe.
Yes, it is a form of prevention, like you said,
PrEP and PEP.
PrEP and PEP. Yeah, now I do get to hear a lot of people talking in public places, in discos and clubs about PrEP and PEP. The main thing is, of course, first and foremost is prevention, okay? And if you put yourself in a situation where certain things are unavoidable, when it comes to PrEP, PrEP stands for pre-exposure prophylaxis, right? Prophylaxis is anything that we do to prevent the spread of a disease. So when we say pre-exposure, it means this is now taken by people who do not yet have HIV, but they are at risk for acquiring HIV through a particular behavior of theirs, which could now be casual sex or injecting drugs. So PrEP again is not something that you joke around with. You would, if somebody is put on PrEP, he or she must be having a high risk behavior. So it is important to advise these people that they need to take the PrEP every day, because even if they miss a single day, the amount of drug in the bloodstream goes down, and the minute they are exposed to HIV, it takes hold, and then your whole PrEP, everything becomes absolutely useless. So we recommend PrEP for people who have high risk behavior, who are probably living with a partner whose viral load is quite high, who have obviously, recreational drug use and sharing needles and all that. And again, PrEP is recommended for people who have taken multiple non-occupational PEPs. Okay, so I get to see all the time in my practice, Diani Beach is obviously a touristy place. So I've seen a lot of tourists who come to me and then say, oh my God, this happened last night, can I have PEP? First time I would sympathize with them obviously, but the same guy comes back 3 or 4 times now with the same kind of behavior. Now that is a candidate for PrEP. He's not a candidate for PEP. So, you know, because he's got a risky behavior and I can't keep giving a post-exposure prophylaxis. So I might as well talk to him and say, listen, your behavior, unless you modify it, you probably are a candidate for PrEP and not PEP. So people who are having recurrent or non-stop, non-occupational PEPs are candidates for PrEP. It has also been documented that with regular, frequent, daily use of PrEP, the incidence of acquiring HIV through sex is reduced by 99% and through injectable needles by 74%. But that does not mean that you want to put things in your body and try and act, in a high-risk behavior. As we said, still prevention is the best method, and we have much more economical and easier ways of prevention, like using condoms properly, avoiding sharing needles, practicing safe sex. These should not be substituted for PrEP. PrEP is only for those few conditions which I mentioned, and it should be advised by healthcare providers. It's not that you just get into a pharmacy and go and take medicines and then exactly.
And interesting, like you rightfully put it, there's a lot that the medic would have to take you through for you to understand this. I know we do not want to get into technicalities, but just briefly, how different is the consumption of PrEP for women and men?
Although I would not be able to give you any statistics off head, PrEP, I think, like for example, if a person is a casual sex worker, for example, it's a woman in the casual sex work business, I think it would be very interesting to probably advise them to take PrEP, because they are exposing themselves day in and day out. You cannot blame them. It is probably certain social circumstances that led them to that situation, but they need to be advised that they probably will be better off taking some sort of PrEP and preventing themselves from being exposed, because you do not know the client who comes to you. We have no idea who they are, where they have been, and all those kind of things. So, so it's better for them to consider using PrEP. The other thing, of course, now we want to talk about PEP, which is post-exposure prophylaxis. Now, post-exposure prophylaxis is obviously given to people after they have been exposed to the HIV virus. Ideally, it should be given within 72 hours after exposure, and the sooner the better, because every hour counts. So if supposing somebody, like for example a healthcare professional, if he or she has pricked herself with a needle, within 1 hour or within 2 hours if you start PEP, the risk can be reduced to almost 99%. There's still a very slight 1% risk, which of course we cannot do anything much, but we can cut down the risk by a significant proportion. So post-exposure prophylaxis involves taking drugs, a combination of antiretroviral drugs for 28 days. Some people can have side effects like nausea and vomiting and a little bit of yellowish discoloration of the eyes, like jaundice, whatever. So, but it's not life-threatening, and it can be managed with simple measures. So post-exposure prophylaxis is recommended for some people who have come into contact with another person during a sexual encounter because they did not know their status, and so we probably would suggest for them. We would suggest it for people who were sexually assaulted for no fault of theirs, so obviously they need to be given post-exposure prophylaxis. Occupational and healthcare workers, because they are now exposed to the risk after having a needle prick or body fluid splash or whatever, and people who are sharing needles and when they come to know that the partner is HIV or something like that. So PEP is quite useful, cuts down the risk tremendously, and it is necessary to be started within as early as possible, but no later than 72 hours.
All right, well, that's good. I wanted to ask something to do with the side effects, which I think you have mentioned, very, very important. With the medication or the treatment that was sanitary, there's also some notable side effects to them.
Like every antiretroviral drug has got its own side effect and safety profile. And remember, we are using a combination of drugs. So the side effects do tend to add up, but none of them are so dramatic that would warrant a patient to stop medications. So most of the time you would experience a little bit of nausea, vomiting, maybe a little bit of yellowish discoloration of the skin, jaundice in the initial stages, but a vast majority of patients do continue and they are quite stable without any of the side effects. As I mentioned, we have certain newer drugs which are better in their side effect profile compared to the older drugs we used to have. The other thing, of course, is because these people, when somebody is on highly active antiretroviral therapy, they may have intercurrent infections. So there could be interactions with other antibiotics we might use or other medications we use. So best left to the healthcare professional to discuss with the patient, and the healthcare professional obviously will go through all the available drugs, and it's like tailor-made to each patient as to this will suit you because you're taking these medicines, it will not interact, and so on and so forth. The other significant thing we see is in developing countries, HIV patients tend to get tuberculosis. So some of the medicines we use for tuberculosis interferes with the HIV medicines.
Okay.
So we need to now know which ones to use and which ones to avoid, and it's more of a juggling the various available options. So again, it is obviously the best decision is made by the doctor in the best interest of the patient, and we would always like to put our patients on the least side effect profile drugs so that compliance is increased.
All right.
Yeah, there's no point giving a drug which will make you throw up every day or gets you diarrhea every day. You're just going to come to the doctor and say, hey, doctor, it's not working, I don't want this. So it doesn't work. So we probably will try and give you something which definitely, fits into our day-to-day lifestyle and all those kind of things.
All right, so towards the last minutes, and I know this was now become sort of random questions. When one gets to this, that aspect of discreteness from the health sector or from the health facility that you go to, just how important is this? Or is it an open affair once you walk in? Because one of the reasons why most people would fear even going to hospital, because they feel now we will walk around and everybody will clearly know that this is where you're headed and this is the problem.
So we, in developing countries, unfortunately, we have a heavy burden of the disease and also we have a heavy stigma, right? We have instances where in certain hospitals, like government hospitals, there's a separate entrance and a separate clinic where they dispense these HIV medications. So obviously, if somebody is queuing up in that queue and somebody else, known person sees him, so it causes a lot of these, stigma. First and foremost, I think we as healthcare providers, we should stop segregating your facility as you go, this is for HIV, this is for TB and all these kind of things. So we probably should have all medications under one shelf, one pharmacy, and everybody should be just treated as normal or, routine cases. Like, this stigma associated with HIV is really something which is very developing country thing. Like, I know of a person who acquired HIV because he was an occupational hazard. He pricked himself, a surgeon, I know, a colleague of mine, and this is in India. I'm talking of like 15 years ago, 20 years ago. So he got HIV, unfortunately, despite having taken PEP. Those days, PEP was probably not the best. And now, whenever he gets into a situation where people come to know, the first thing they say is, oh, he must have done some mischief and this and that. So this has to get out of our mind. We should get out of this attitude of branding somebody as being mischievous or whatever. We all make choices in life. Some of the choices we make are good, some of the choices we make are foolish. But yes, we do regret at some point of time for the choices that we made in lives. But we can't be held responsible for it, and you can't put the proverbial sword of Damocles around my head. And I think this attitude should change. And it is definitely not something which is, something to ostracize the person from the society. You must integrate these people in the mainstream because they are as much a human being as you and me are, and there's nothing, it is, as we discussed, it's not going to spread by touching or kissing or handshaking or whatever. So they're just leading an entirely normal life, and we just support them. They need all the support they can get. So I think for basic medical health care, and it was quite tedious for them to get across the ferry and do all those things. So the hospital was as long as they're adherent to the drugs and compliant with the medications, we told you that they can have a near normal life expectancy. So, I know of a patient who was one of the first to be diagnosed in this country. Since 1991, when we first diagnosed, today is 2022. For 31 years, she has been through all the medicines which we have, put her on, and now she's almost, I think, 60, 65 years old, whatever, and very healthy.
All right, great.
Very, very healthy, and there's no problems at all. We have with us top consultants in almost all specialties. We have ultra-modern. Many take-home messages. First and foremost was that we did mention that HIV positive people should be integrated into the mainstream. They are as much an individual or a human being like you and me, and they are not to be ostracized in the community, and we must give them all the support system that they need. That is main message from that. The other messages, of course, will be that we must always take precautions, and not put ourselves into risky situations or dangerous situations.
Yeah.
And we must almost always make sure that every one of us get tested at least once a year, more often if we're having any risky behavior. And we must also ensure that if at all some of us have been diagnosed with HIV, never ever stop taking the medications, because these medications mean life or death. So if you continue to take the medicines, and you can have an entirely normal life, so please stick to your doctor's instructions. The other thing is, coming from 1981 to now, in these 42 years, our knowledge of HIV and AIDS have grown leaps and bounds.
Yeah.
The quality of healthcare that we can give to our patients is improved dramatically. Right? Cost of medications has come down. We have now got better medicines with lesser side effect profile, so people don't have to be scared of the side effects. There is a lot of research going on. There is probability of a vaccine coming out in the future, so it could become a vaccine preventable disease. But till such time, the biggest weapons we have, of course, is to practice safe sex, is to avoid dangerous situations like injecting drugs and all these kind of habits, to get tested frequently, and to talk with your friends and family members about HIV, how you can prevent it. And of course, one person can tell 10 can tell 100 can say 1,000.
Right.
So word of mouth, everybody should be talking to one another and advising them and telling them to prevent where every time is possible. And I think that will in a big way be our main weapons in the battle against conquering HIV. 38 million people globally living with disease, and of which 28 million people have been over treatment, so that's not a bad figure at all. And compared to